So a question I've been thinking about today is, does the quality of care, the standards of care and the outcomes for inflammatory bowel disease patients differ depending on where you live? I've been thinking about that because a reporter from Scottish TV came today to ask me these questions, indeed, for a piece that's going to air shortly. And I thought I'd just expand on that a little bit here. The quality of care, I think, for newly diagnosed inflammatory bowel disease, and indeed patients with established IBD now in 2024, as we get towards the end of the year, is really fantastic in many, many parts of the world. I think we pride ourselves on excellent quality and standards of care here in Edinburgh, with really a well-established and quite sizable team to look after the many, many people we have living with Crohn's disease and ulcerative colitis here in Edinburgh. But I think the sad truth is that this is variable. There are some pockets where this isn't as good. And it's partly just to access to specialists, it's partly funding, it's resourcing. I think there are many different reasons why this is the case now, and it's definitely something to work on. We need to make sure that people are diagnosed early, because we know that that makes a big difference in terms of improving outcomes, and Crohn's and Colitis UK have done some fantastic work on this in terms of raising awareness in recent years. And then after diagnosis, patients straight into specialist care. We know that the keys to a good life with Crohn's disease and ulcerative colitis are getting patients specialist care early after an early diagnosis, and then early and effective therapy with target-driven management, and to do that with a holistic patient-centered approach. That's the way to really make a difference, because we have many effective therapies now, and the effective therapies that we have are cost effective too, so there's no reason not to use them. There's none of this nonsense anymore about patients having to earn their right onto an effective therapy. We really should be using our best drugs first and not saving them in our back pocket for a rainy day. We've looked at this in Edinburgh, we've studied this, my team. We see that when we use early effective therapy, we change the outcomes. Patients are better, they have fewer hospitalizations, they have fewer major surgeries, they have a better quality of life, and there's no reason not to do this. So yeah, kind of a few things to think about today. How do we improve standards of care across the piece? Because if we really want to change the outcomes, that's the thing to do. Get more people with IBD across the country, across the world, into specialist centres where there is access to that full team of, consultants, fellows and trainees, IBD nurses, an effective helpline, psychologists and dietitians. I mean, we don't have access to that in any meaningful way for our IBD patients in Edinburgh, except for extreme situations. And then you need also, of course, expert surgeons and radiologists and pathologists, access to rheumatologists, dermatologists, ophthalmologists, and others who are interested in IBD, because these are illnesses that are inside the gut, they're outside of the gut, they're skin, bones, joints, eyes, and the profound psychological upset as well. But all of that, with so much of that, where inflammation is driving the damage over time, that we see the irreversible bowel damage over time, we know that if we can get patients appropriately treated early on, we do change the natural history of the disease. It's not perfect, we can't do it for everyone, but I'm really optimistic about this just now. We are making a big difference, but we must try to get to those pockets where things aren't there. So I'm going to come back on this more in a minute, because it feels like it's an important topic to dive into in more detail.